Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Year in Review. As today we talk about the management of gastroesophageal cancer with Dr. Eric Van Cutsem, Professor of Medicine and Digestive Oncology at the University Hospitals Leuven in Leuven, Belgium, and Dr. Suni Kim, who I met with a couple of weeks ago to record a presentation. I'll tell you a little more about it. From the University of Colorado Cancer Center in Aurora. She'll be appearing today by video. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room and we'll talk about as many of these as we have time. We put a 1-minute pre and post meeting survey in the chat room for you to take. If you take that, you'll get a lot more out of this meeting. We actually did another program earlier this year, a couple months ago, with Dr. Janjigian and Weinberg, looking at data sets, but again, there was just so much to cover, we decided to put in this second version of it, but this one's now available online. Next week, we'll be doing AML and Year in Review with two docs from the biggest leukemia center in the world at MD Anderson. And then we'll be heading out to Washington, D.C., as we do every year, this year in Washington for the Oncology Nursing Society Congress. We're putting on 10 programs. Any nurses on the line or that you're familiar with in the Washington area, it'll also be put out there. And you can see we have a GE series there as well. It'll be online as well. Right after ONS, we'll be heading out to San Antonio for the AUA meeting. We'll be doing a program on prostate cancer on May the 3rd. We'll do another program in a year in review. It seems like it goes on looking at targeted therapy and non-small cell. So much happened over the past year. But today, to me, this is one of the most challenging topics we have in oncology today, gastroesophageal cancer. I always look forward to speaking with Professor Van Cutsem, and as always, we will talk about non-approved uses of agents or refer to prescribing information for specifics. This is the first part of this program that's in the chat room if you want to look at it now, but when we send out the replay of this webinar, we'll put that in too. This is Dr. Kim's review of some of the key papers of the year. We also talked a lot about it, and I asked her some things that I'm going to bring up to Professor Van Cutsem. Here are the papers. We're not going to talk about all the papers here, but if you check out her talk, she goes through all these papers, and we discuss it a lot. And then at the end of her talk, she presents 4 cases. And Eric, what I thought I would do today is kind of flip it around for you and actually start out with her cases, talk about that, and then we'll talk about what's happened over the past year that maybe relate to cases. So how you doing? I guess it's late in the evening for you here in Belgium, Belgium?
Yeah, it's 11 p.m. and good night, Neil and team. Happy to discuss with you as always, but I'm fine. It's not yet midnight, so I'm okay.
I always prided myself in being, I hope, being the one who introduced you to 1980s rock and roll, the music we play at our meetings. But we got a few new songs.
Yeah, one of your trademarks, and that's always nice to hear.
Yeah, we like add maybe one new song a year. All right, let's talk about localized disease and particularly the issue of immune checkpoint inhibitors. And again, here are some of the papers that Suni talked about. But I want to run this case by you, and I have a little kind of interesting angle here. So this is a 55-year-old man, localized, poorly differentiated signet cell adenocarcinoma, gastric adenocarcinoma. He was seen by a community-based oncologist, had a workup, and then turned to the oncologist and said, "Did you get MSI testing on me?" And the oncologist said no. And he said, "Well, I've been reading about it. I think you ought to do it." And he got it, and it was MSI high. The doc put the patient on Ipi-Nivo a la Neopenga, but he ended up transferring, maybe lost a little confidence in the doc to Dr. Kim. Before you hear more about the case, just for fun, Eric, would you like to guess what the patient's occupation? And remember, he actually looked it up, found it, and then got another doctor. So a pretty proactive patient. Just thought you might want to take a guess at what do you think?
Either it's a school teacher or a physician.
School teacher or physician. We are actually wrong. But anyhow, before we get into it, here's the case.
These are all real patients of mine. So this is a 55-year-old man who initially presented with abdominal pain, bloating, reflux for 4 months. And then he went and got an EGD after a few months of these symptoms. And he found a 6-centimeter ulcer in the gastric fundus. The pathology had a lot of poor prognostic features. It was poorly differentiated, diffuse type signet ring, but also had loss of MLH1 and PMS2. And this is the patient who actually advocated for getting MMR testing and MSI testing. And we did confirm that the tumor was MSI high. And so his oncologist looked at the NeoNepega study and did start him on ipilimumab, nivolumab. So he ended up actually switching care to us because he just really wanted to, work with someone who was really up on the literature. So after 3 months of treatment, 12 weeks, he had a CT chest, abdomen, pelvis, which showed interval near complete resolution of the gastric wall thickening. And so after much discussion, we decided to continue IO and reassess again. He had some new dyspepsia, so we decided to do a PET scan a little bit on the early side, and we found that on the PET scan a month and a half later that there was no FDG-avid disease. And at the very beginning, his disease was FDG-avid. I recommended we also get an EGD too, and there was no obvious visualized disease, and biopsies were taken. And this is late breaking news, but the pathology was negative for malignancy. There were no signs of cancer on biopsy. So now we are in this interesting situation about what to do. Should we continue IO? Should we take him to surgery? He's young, very fit. He could easily tolerate the surgery. And he's talking to other patients to see what the surgery is like and what life is like afterwards. But gosh, I wish this was, 2 years later where we had results from the Infinity trial, because the Infinity trial did have some data in the watch and wait cohort. So it'd be nice to know. But at this point, I am still recommending surgery given his good physical condition, but it's a very interesting question about what to do with these patients.
What was his background that he found out about MSI and was so proactive? What kind of work does he do?
He's a lawyer. Yeah. He's a lawyer. He's very used to digging through a lot of literature.
So I was just flashing as she was presenting that this is maybe GE Cancer 2030, hopefully, that we can treat people and maybe not even have to do surgery. We're just beginning to maybe see the beginning of that with MSI high disease. So any thoughts about the case? Also, I asked her about cell-free DNA and curious whether you think that would be helpful here.
Yeah, I think it's a very interesting case, and I think this is just the new evolution that is coming through. And the last year we have seen some of this interesting data. I think these patients, we should offer them the chance to benefit from checkpoint inhibition. Nivo-Ipi is the best option. In the setting with the combination of a PD antibody plus a CTLA-4 antibody. And if you look at the data coming from a couple of studies right now, there's a quite good chance of having a deep response, a complete response, which persists. And in a patient like that today, I would not, if you don't find anything on a PET-CT, with the caveats that a PET scan for a diffuse type may be negative, but in the beginning it was positive. So in good imaging, sometimes we do an MRI in this setting also. And then with an endoscopy also with negative biopsies. If that's the case, we would go with a watch and wait approach and not to do an operation. Discussing, of course, with the patient. The patient has to consent on that he doesn't go for an operation. But I don't think we can lose a lot in this setting. We can avoid an operation and potentially some morbidity after the operation. I think that's the better option in this setting.
Any thoughts about whether cell-free DNA would be helpful in this situation? And how much data do we have on single-agent neoadjuvant IO in MSI high?
We don't have a lot of data of single-agent IO. So in the situation where we would really do it in the neoadjuvant setting, the label is not there in Europe. It's out of the label, but the best is to go with a combination. We have the data from the Checkmate study that Nivo-Ipi is active in this setting. So I would rather go for the combination. because the response rates are clearly much higher than with Nivo or Pembro or tislelizumab alone in this setting. Whether cell-free looking at circulating DNA, probably we would do that, but there are some caveats in this situation. In Europe, it's a bit less spread in community oncology center for sure, but also in academic centers to look into this setting. But I think it would be a nice thing to have to do, but I would trust more, let's say, on the endoscopy, the biopsies, and then good imaging. In our center, we integrate, as I mentioned already, a lot of MRI, also in this with diffusion perfusion MRI, which helps to detect a bit with more sensitivity compared to CT scan and PET-CT also. But I do know that that's not standard practice, not everywhere. But yeah, I would not be a fan of circulating DNA, although it may be nice to have in a situation like this.
Yeah, I mean, I was thinking maybe, if the patient's on the fence about surgery, if it were positive, maybe it would help to encourage them to
Correct, and
consider
then you would
that.
go for surgery, of course. But I think it's very unlikely that this is positive if with adequate imaging and adequate endoscopy, nothing is found in a patient like this. I think it's for sure not more sensitive.
So hopefully someday we'll be in a situation where we can have MS stable patients getting treated like that. And here's the NEO-PIGA and the Infinity trial that is discussed more by Dr. Kim, but also the issue of post-neoadjuvant therapy. Eric, of course, we now have standardized the use of post-adjuvant Nivo or post-neoadjuvant Nivo in people who get a neoadjuvant cross, but everybody's always asking about FLOT and gastric cancers. And one of the things that Dr. Kim talked about was the Keynote 585 study with Pembro, which unfortunately with longer follow-up really doesn't have a survival benefit. And then the new data that you all presented at ESMO on the Matterhorn study, I guess similar but not exactly the same, but earlier now, we're seeing past CR at this point. They don't have more follow-up. Any thoughts about where this strategy is heading, where Matterhorn might land?
Well, Matterhorn, we don't have long-term outcome data. We have the data on the downstaging and downsizing of the tumors at the moment of the operation. There was a quite big difference in that sense that patients who received preoperative FLOT for 2 months plus Durva had clearly more tumor regressions, deep responses, and also complete responses compared to patients who had FLOT alone in the setting. The difference, it's always difficult to do cross-trial comparisons, but there are some differences with the Keynote study, but there are some differences in the design. The Keynote, the majority of patients received the chemo doublet. There were some patients with the chemo triplet with FLOT. Here in the Matterhorn was more pure. All patients received chemo triplet. So it's a big study, almost 950 patients. We should see in the near future outcome data. It's difficult to predict, but I'm quite optimistic that the study may improve the outcome for patients.
So we decided to enhance our slide deck here, and you can check out this paper that Dr. Kim talked about. And we have a number of trials in progress. These are all papers where you can not only see the design, but the rationale. They're usually abstracts with posters. So they're really great references to take a look at some of the trials that are looking at localized disease. When you look through the list, it's kind of interesting. That one, Association of Gut Microbiome Diversity with past CR after neoadjuvant treatment of rectal and esophageal cancer. Are you a big microbiome person, Eric? Are you doing any research in that area?
Our team is doing research on that, not specifically in upper GI cancer, but more in colon cancer. one of my coworkers is doing that to see the relationship with microbiome and polyps, more in the early carcinogenesis of colorectal cancer. But I do think that the microbiome is that's a statement is important. We have some data also that with the microbiome we can influence the activity of checkpoint inhibitors. That's just one of the important topics. It's not yet clear, but the data are accumulating that this may be relevant. We don't know, and I don't know at least, and I don't think we know how to influence that clearly. But that I'm convinced and optimistic that there will be some relevant data in the next coming years in this situation.
At this point, do you kind of discourage or stay away from using antibiotics and treating patients if they really don't need it? Or are you concerned about changing the microbiome?
Yeah, if patients don't need it, then we don't treat them with antibiotics. That's obvious. So we think always twice, do the patients need antibiotics? But of course, in cancer patients with receiving chemotherapy or with their immune suppression, we need antibiotics. We cannot lose patients, of course, because of an infection that is not adequately treated with antibiotics.
Yeah, I don't know whether you maybe think twice if you have a patient on a checkpoint. Anyhow, what about, we were talking about this first patient. Actually, this man, the attorney, he didn't want to have surgery from the beginning when he was first diagnosed. So he was also concerned about the surgery. And I was curious kind of what's new, because we found a trial in progress looking at single arm as a phase 2 trial, laparoscopic robotic total gastrectomy with spleen preserving splenic hilar dissection for locally advanced proximal gastric cancer that invades the greater curvature. Is this less morbid surgery? And if so, like, who can get it?
Well, our Japanese colleagues are heroes in gastric cancer surgery, that's clear, and laparoscopy and robotic surgery. Laparoscopic surgery is done in all patients, or virtually all patients with stomach cancer. Robotic is also coming to the arena. It will probably have a little bit less short-term morbidity with laparoscopic. We have data also that oncological outcome is fine in this setting. But having said that, there will be still some morbidity. A surgeon who tells me that he has no complications, I always give him the answer, then you never operate. So there will be always complications with surgery. So like with immunotherapy, there may be complications also. But yeah, I can follow the patient of clearly. If I was a patient with what I know today, I would do for myself the same in this setting. If I would have an MSI-high tumor, going for checkpoint inhibitors, and then following very clearly. If there is any doubt that there is residual disease, there is no doubt that surgery should be done. But if there is no evidence at all, you don't lose. And then you can follow, like we have learned a lot in rectal cancer with the non-operative management. We follow the patients very strictly with endoscopy and scans, MRIs usually in rectal cancer. And then if you see a regrowth, you do an early operation, and then you can still do a minimal invasive operation in rectal cancer. Sometimes in upper GI cancer, it's going to be the same. It will be extremely rare that you will lose in the meantime patients with metastasis in this setting. If that's standard, no, I don't think it's standard to propose that for all patients. But I think it's an important option that should be discussed with patients, and especially also in elderly patients where the operative risks are a bit higher. I think there it becomes often the preferred option in a patient with a situation like the interesting case that was presented here.
So we're going to move on now and talk about HER2 positive disease. And I always viewed you as sort of the father of HER2 positive gastroesophageal cancer. And actually, probably people who are new to oncology maybe don't even know, because I'm a big fan of cool trial names. And I always love the TOGA trial that you did with trastuzumab. now, great that I'm talking to you today, because just a few days ago, we saw pan-tumor HER2 approval. I can imagine, you would never imagine that when you first started to talk about the TOGA trial. Of course, there you were really for the first time moving HER2 therapy beyond breast cancer. Before we talk about what's new, particularly TDXD, any reflections you have back on, when you first thought about the idea, what was going on in breast cancer at that time? Did it meet your expectations? What was it like, doing anti-HER therapy? You're the pioneer.
Yeah, we did a study. We designed the study. I don't remember exactly the year. We published the data of the TOGA study in 2010. So the design has been a couple of years before, 2006 or 7, something like that. At that moment, many oncologists, including myself, we were a bit skeptical because there are some differences between HER2 positive gastric cancer and breast cancer. But we said we need to make progress with chemotherapy, doublets, triplets. We didn't improve so much anymore the median survival of these patients. So we said, let's go. And this was really a pivotal experience, which exceeded our expectations. And then after this initial TOGA study, there were also some disappointments. The study with TDM1 in second line, which was positive in breast cancer, failed in second line gastric cancer. The study with the combination of trastuzumab, pertuzumab, which was positive in breast cancer, failed also in gastric cancer, the Jacob study. And then there was a period of depression. But now, over the last couple of years, as you said rightly, some new drugs are coming into the arena, which are good to see also active in stomach cancer.
So we're going to get into that with a case as well. Here are some of the papers that Dr. Kim went through. The patient that she presented actually is actually got sort of TOGA first line, CPS is 0, which is pretty interesting. And now is getting second line therapy as well. Interesting that the CPS is 0. We had another case I was telling her where HER2 positive. Most of them are CPS positive, but this one was 0. Anyhow, here's the case.
He initially presented with dysphagia, iron deficiency anemia. An EGD was done showing a large fungating mass with bleeding in the distal esophagus. HER2 testing was done. It was 3+ on IHC, also mismatch repair proficient. A PET scan unfortunately showed metastatic disease, multiple FDG avid, mediastinal, upper abdominal lymph nodes, and liver mets. He was started on full FOX trastuzumab. Initially had a good response, but had progression of disease in liver and esophagus after 8 months of treatment. He actually came to my care after that. I repeated an EGD before deciding on the next treatment. I like to repeat biopsies to see if the HER2 expression is still high. And it did show that HER2 was 3+ on IHC, and NGS also showed a HER2 amplification. The PD-L1 score was 0. So he was started on trastuzumab deruxtecan, and he did have his first scan recently, which showed interval improvement in the liver metastases. So far, doing well, but I am thinking about that Destiny Gastric 01 and 02 data where the duration of response is, I would say, modest. So we'll see how long the treatment lasts for him.
So for those of you who are only listening, there was a little kind of movement of her lip when she talked about that she told me that I guess that duration of response in the trial didn't look that well, but when you talk to people who've used TDXD, breast cancer, lung cancer, is the first thing they talk about, at least clinically, that I hear, is a good duration of response. Anyhow, any thoughts about this case, HER2 positive disease, and TDXD, of course?
Yeah, trastuzumab deruxtecan is an interesting drug. It's an antibody drug conjugate which is clearly active. Initially, the Asian study showed that. Later on, we did the Destiny 02 study, which was US and European patients. What was different in the 02 study versus the 01 study, and the 02 study we published recently in the Lancet Oncology. In the Western study, patients were second line, no third line treatment, and we rebiopsied. We did a new biopsy in all patients, because from some Asian studies from Korea, it may be that some patients lose their HER2 expression after progression on trastuzumab. So that was particular in the Destiny-02 study. What we saw is that around 40% of patients had an objective response, and the response duration was not too bad. So there, I may disagree with Dr. Kim. Response duration was not too bad, and as you said rightly, also in breast cancer, that's seen, and we saw that in the Western patients as well as in the Asian patients. It's an active drug. The oncologists need to learn how to work with it. Of course, around 10% of the patients will have interstitial lung disease, not easy to treat in these patients. But in the other patients, tolerance, it's a combination of an antibody with a cytotoxic. It's an antibody drug conjugate, so it has some chemotherapy-related toxicity. But the most special, tricky aspect on safety is interstitial lung disease. But in general, the benefit-risk ratio, as we call it, is beneficial. So it's good that we have that drug, that it's approved, and as you said, also now across different tumors, HER2 positive tumors.
One of the things that's really interesting as it goes out into other parts of oncology, hepatobiliary, now we're talking about it, bladder cancer and GU, et cetera. And the thing that's kind of interesting is as it comes into the new fields, GE cancer has been around for a while, but these other ones, colon cancer, et cetera, it's really, and particularly where TDXD is being discussed, it's really interesting to see the investigators struggle with, questions like, what do you do to, how do you manage and look for ILD? How do you deal with side effects, et cetera? And the strange thing is, it's the general medical oncologist has already treated a ton of breast cancer patients who already kind of is used to TDXD. They kind of are more used to it than the investigators. We actually had a breast cancer investigator we showed video of at a GU meeting recently, just because there's so many things going on. And one of the biggest things, you kind of referred to it, is HER2 testing. And the first thought I had when I saw that pan-tumor HER2 approval is, what are they going to do about HER2 low? Because I even see, as you look at all gynecologic cancers, et cetera, in breast cancer, we have a very strict paradigm. IHC 3+, if it's 1 or 2+, they have to be FISH negative. So, or they have to be FISH positive. Outside of that, I don't always see FISH being done. I see repeat biopsies being done, and like you were saying, and if there's not HER2, they don't give, for example, TDXD. So I imagine this is all going to sort of get, ironed out in the next couple of years, but looks a little challenging.
Yeah, it's not going to be easy, but at the moment in the different GI cancers where we have been treating patients with trastuzumab deruxtecan, also with other HER2 targeted agents, it's always for the clearly HER2 positive patients, with as definitions IHC 3+ or 2+ followed by a positive FISH test. If you look at the data of TDX, at least in the Asian patients who were slightly positive for HER2, not the clear positive patients, the activity was not up to the same level compared to the 3+ or 2+ with a positive FISH test. So in this setting, as long as we don't have more clear insights, my guideline and recommendation is to limit that to the clearly HER2 positive patients. These lower categories we need for sure in GI cancer, in upper GI cancer, but also in colorectal or bile duct cancer, as you said rightly. We need more data in this setting before recommending to treat these patients. I would recommend to do that within clinical trials if they are there, but not outside of a trial.
So yeah, it's really interesting to see people start to, think about this whole strategy where they've never thought about it before. Dr. Kim, here's the approval that just came out on April 5th. This pan-tumor approval is going to be very, very interesting. She went through a lot of the data you just referred to, including the 8/11 study. We saw survival data now with that, but again, being restricted to CPS greater than 1. So here's what I want to ask you about. You can imagine we're talking a lot about bispecifics nowadays, but not so much about bispecifics like zanidatamab. So can you kind of talk a little bit about what it is and what we know about it? A pretty interesting type of drug.
It's indeed an interesting drug. It's still under investigation in phase 3 study, so we don't have final data on that. The studies are ongoing, but it's a bispecific antibody binding to two different HER2 epitopes. The epitope to which trastuzumab binds and the epitope to which pertuzumab binds. And then it has some FC-mediated cytotoxicity, some ADCC in the setting, and that antibody is seems to be active. Toxicity doesn't seem to be, from the data that we've seen, a major issue, but the mechanism of action is appealing. And there are some phase 3 studies ongoing right now, also in stomach cancer, in HER2 positive stomach cancer.
Yeah, I wanted to ask you about that because, of course, I think we have it in another slide. It's being looked at in the first line setting where IOs obviously are a consideration as well. What have you actually used the drug in a trial? And Dr. Kim was saying something about diarrhea. I'm not sure how much of a problem that is.
Well, yes, I've used the drug. We are involved. We are treating patients within the Horizon GA1 trial, as it is called. This is a 3-arm trial. Patients receive standard treatment, being a chemo doublet plus trastuzumab. I'm speaking on stomach cancer, or chemo plus zanidatamab, the HER2 antibody, and then is a third arm with chemo plus the new HER2 antibody, plus a checkpoint inhibitor, a PD antibody, teslizumab, which is an antibody which is now approved also in some indications for squamous cell cancer of the esophagus, for instance, which is an active PD antibody also with some ADCC, and that's being combined with zanidatamab. That study is ongoing. The experience, the data on toxicity, there are not yet in public domain a lot of data on this, but yeah, on toxicity, it seems to be okay, I think, if you look at the initial data from early studies.
Interesting. So you mentioned tislelizumab, which, as you say, is in this phase 3 trial looking at zanidatamab. I'm curious, I read about the fact that it's slightly different than you were kind of alluding to it, slightly different than the other checkpoint inhibitors. Can you explain how it's different and your thoughts about why that means anything if it does?
Well, we don't know clinically whether it's better compared to nivolumab and pembrolizumab. We know that it's active. We have seen some data in esophageal cancer, in gastric cancer. There are some other diseases ongoing where the drug is being tested. It seems to have some ADCC component. Whether that's going to translate in more clinical activity, that's difficult to say. I think a fair statement is probably that we can say that it's at least as active compared to Pembro and Nivo, with the caveat that there are no comparative studies. The studies that have been done is chemo plus or minus tislelizumab in these different indications, adenocarcinoma and squamous cell cancer of the esophagus also. And the initial study was a study that trios study, this is called, which was a second-line study of tislelizumab versus chemo in squamous cell cancer of the esophagus, leading to a clear benefit. And then there was another study being done. This one, the Rationale 306 study, is a first-line study in squamous cell cancer of the esophagus, in which patients were treated with either chemo or chemo plus tislelizumab, with a big difference, regardless of the PDL CPS status. The difference was, the benefit was even bigger in patients with a high PDL score if we speak on squamous cell cancer. But the study was also in the intention to treat population positive, which is all comers. Here they used the TAP score, PDL TAP score in this study. So there is an enrichment, but as you can see here, in patients with a low TAP score, less than 10% of the cells, with less than 10%, there was a clear benefit also. So this drug seems to be active. It's approved right now in second line in Europe. I don't know what's the status in first line combination for the approval. It's not yet approved in Europe. I don't know in the US.
You know, one thing I'm kind of curious about, you were mentioning this trial combining it with zanidatamab, and you know, one of the issues comes out, we see all these PD-1 levels. This one kind of looks a little bit different in how it works, but we're not going to be able to have a comparison study to some of the trials with Nivo and Pembro, and it's very difficult to, there could be a difference there. We probably wouldn't see it, but you know, just kind of reflecting back on how we take research into practice. So, you know, you have all these IOs out there, and I see what I call the Pacific trial effect. So I don't know if you're probably familiar with the Pacific trial in non-small cell lung cancer. So in metastatic non-small cell, everybody gets Pembro, either alone or with chemo. It's like all over the place. But in post-chemo radiation, the Pembro trial didn't look very good, but the durvalumab trial looked really good. And so everybody does that now. So is that kind of the way things go as we get new IOs in? Is it an issue of, are you going to substitute it for an IO monotherapy? Or really that if a trial's done, for example, if this trial, the Horizon study is positive, would you use tislelizumab, or say, oh, well, Pembro's just as good?
Well, if your question is what would you use, then in Europe at least we are even more linked and asked to stay in label. So if that trial is positive, then we will use tislelizumab. With that, I didn't say that Pembro and Nivo would not be active in this setting, but it's that's like in the first line, the Keynote 811 study was done with Pembro. May well be that Nivo in combination with trastuzumab would also be as good, but the trial is not done in this setting. In theory, you could substitute, but the trials and the label is restricted for the specific agent in this setting. So we don't replace this. What can, where we have more and more data is that, as we know, different antibodies are being used for PDL testing. It's probably less relevant which antibody we use for the PDL testing on the tumor, as long as the pathologist is experienced. And then we have different methodologies, PDL CPS testing, the TAP score, just the positive tumor cells, the percentage. Probably that doesn't make a big difference in this setting. We see in gastric cancer more and more a trend towards going towards PDL CPS reporting and testing. But the TISLI study, as you showed rightly, was done with another methodology. We've seen some data that probably, if you look in the higher cutoffs, probably doesn't make a big difference in this setting. But there's a trend towards PDL CPS testing in Europe for sure, and globally also.
So we just did one of our weekend with general medical oncologists where we brought in 35 investigators here in Miami. We cover like 25 tumor types. I was just thinking about one of those docs, and we didn't even cover like 2/3 of oncology. Listening to what you say and having to, kind of process that along with stuff in bladder cancer and CLL, et cetera. Pretty interesting being a community-based general medical oncologist. And hey, there's another challenge that may be coming along real soon, zolbetuximab, which is going to be a little bit different from what I can see in terms of management. But again, we're going to go into a case. But before we do, I just got to ask you, here's a scenario. Young patient, 41 years old, presents short of breath, hypoxic, with a lung full of tumor and a primary GEJ adenocarcinoma. So whether it's full-blown visceral crisis, it definitely did not sound very good at that point. Interestingly, the claudin 18.2 was positive, the CPS was 2. Before you hear about the patient, how do you think you would treat a patient if you could access zolbetuximab, or this patient?
Yeah, I would treat this patient today with chemo plus zolbetuximab if the tumor is claudin positive and PDL CPS 2. It would be more difficult if you would tell me PDL CPS 20 or 10, then I would rather go for a checkpoint inhibitor. In Europe, we restrict Nivo, for instance, is only approved for PDL CPS 5 or more. And if you look in gastric cancer, as I said already, the higher the PDL score is, the better the activity is of the checkpoint inhibitor. So this is a relatively low PDL score. In Europe, it will fall out of the label, and the benefit of a checkpoint inhibitor is quite limited. So a patient like this, I would treat with chemo, Folfox plus zolbetuximab.
So if the CPS were 20 and you could access both drugs, again, you got a patient in visceral crisis, CPS is 20. What about giving both? If you could.
We don't have data yet. There is some. There are some studies ongoing with zolbetuximab plus a checkpoint inhibitor. There is also, as far as I'm aware, a study ongoing. I haven't seen data yet of chemo plus Chinese osimertinib. I can't recall exactly the name and I can't pronounce it yet. I have to practice, but of the company Transcenta, and also with the checkpoint inhibitor. But these studies are ongoing. If you look at clinicaltrials.gov, we don't have yet any data in the setting. So I would not, even if the patient is in crisis, I would not combine them today. You don't know what's going to be the interaction with the antibodies. We don't know what's going to be the toxicity. Doing that right now without having any data, I would strongly not recommend that.
So before we hear the case, quick question from the chat room. Do you use CT imaging of the chest in patients who don't have symptoms, 1-TDXD? The breast cancer people try to get scans, as often as they can, or usually doing it every 9 weeks for at least a year, maybe longer. Very aggressive about looking for asymptomatic grade 1. Does that apply to GE cancers?
Yeah, we do that. We do that systematic. Anyway, we do an evaluation of the tumor status every 2 months, usually in clinical practice, sometimes 3 months, but many patients every 2 months. We do in one session a CT of the chest and the abdomen. So we look at the lungs, of course, to look at metastasis, and in these patients also we will detect with that. Hopefully not, but we may detect ILD.
How about the breast cancer strategy of, if they're grade 1, they're asymptomatic, you can wait until they recover after steroids and potentially retreat, but grade 2, any symptoms, breast cancer people will not repeat. Agree or disagree?
Completely agree. Not to repeat. If it's grade 2 with symptoms, we until now we take off the patients of ILD.
Well, Ken, you've been in the field for a while, but a lot of the people outside of breast, when I say, what are you going to screen for ILD, the first thing out of their mouth is something about, clinical symptoms, hypoxia, et cetera. And of course, the breast cancer people say you got to get it before then. Well, let's hear about this case of this patient with hypoxic with a claudin positive. Turns out he was, thankfully, eligible for a trial you may have heard of. Here it is.
This is a 41-year-old man who initially presented to the emergency room with dry cough and new oxygen requirement. A CT chest showed extensive pulmonary nodules, and then there was a subsequent PET CT which showed the primary, the distal esophageal wall thickening with mets to the left adrenal gland. EGD was done. It was biopsy confirmed moderately differentiated adenocarcinoma. So this was a patient who did enroll in the Spotlight trial. His claudin testing did show high expression of claudin 18, and he was randomized to Folfox Zolbe. Very classic. He did experience significant nausea, vomiting during cycle 1. the infusion was slow to half rate. Additional antiemetics were administered, and he was able to tolerate completion of the Zolbi. So with maximal antiemetic drugs, fosaprepidan, aloxi, dexamethasone, he was able to tolerate the subsequent infusions. The first scan did show improvement in lung nodule. He had previously been on O2, and he was able to wean down his O2 requirement. Unfortunately, he did experience disease progression after 6 months of therapy. I do feel the majority of patients who are Claudin positive, now that I've been routinely sending NGS on all my patients with Claudin testing, I find that the typical scenario I see is HER2 negative, PD-L1 low or zero, and then they're Claudin positive.
Any thoughts? And I was thinking about the Venn diagram because that's kind of the way it looks. So Claudin, PD-1, and then what, maybe 10 or 15% both?
Yeah, there is a small group, as you said, 10 to 20% who may have PDL positive tumor in those with a Claudin positive tumor. It's a small group. Usually they have a low score. That's at least the data that are out right now in this regard. So in this group of patients, and maybe in others also, the interesting question is, of course, combination of a Claudin plus a antibody plus a checkpoint inhibitor. But usually in the Venn diagram, there is some overlap, but there is not a big overlap. In the future, we may come up with other markers, FGFR. Then we will have to look in detail more in the Venn diagram to see how much overlap there is again with some of the other markers, upcoming markers.
And of course, you know, we're always talking about the advantages of the clinical trials. You couldn't find a better case than this one. If that trial had not been available, I don't know what kind of, this patient would not have much options. I mean, I guess could get chemotherapy, but certainly it seemed like he had a useful response. So it would have been great if it could have been longer. I want to really get into the issue of the nausea and vomiting, because it's just trying to put a big, sign out there to oncologists, be ready for something different, because what I'm hearing sounds a lot different than what I've heard before, like chemotherapy and other types of nausea and vomiting. But first, can you just briefly talk a little bit about how the drug works and also other strategies to target Claudin?
Yeah, the drug works on, is an antibody that binds to Claudin, which is in the tight junctions in the stomach, but also in some other tumors. So there are now some data in pancreatic cancer, or some studies ongoing, not yet data, in pancreatic cancer, because some of the pancreatic cancers may be Claudin positive, some of the bile duct cancers also. So this Claudin antibodies, obituximab and others also are under investigation in this indication. So it's completely, the patient, as was presented by Dr. Kim, completely illustrates very well what we saw with the safety. So there is clearly more nausea, there is clearly more vomiting. The good news, if we can say that it's good news, is that it's more present in cycle 1, a bit in cycle 2, and then we adapt our antiemetic strategy. Infusions are slowed down, as Dr. Kim said, a bit over longer time. And then usually it seems that from cycle 3, 4, and so on, the nausea vomiting is a less big issue in this setting. But oncologists and patients have to be aware that this may happen in the first 2 cycles with zolbetuximab. It's probably a class effect. Some of the other agents have reported the same. There are other antibodies under investigation, as I mentioned already, some Chinese antibodies. And then there are antibody drug conjugates also, like trastuzumab deruxtecan, but then with another payload and another linker. Under investigation, I haven't seen strong data yet from decent sample size, decent in this with the antibody drug conjugate. Our Chinese colleagues have presented at the ESMO meeting 2 years ago Claudin CAR T cell in a small study, which was not randomized, but indicated that there may be some activity. Much too early to see where that's going. I think it may be complex and all the logistics on CAR T cells, especially that since we do have chemo plus antibodies or antibody drug conjugates maybe in the future for this group of patients. But yeah, there is with the Spotlight and Glow study with zolbetuximab, not yet approved today, hopefully in the near future. There's a lot of activity ongoing, and that will, as I said already, expand to other indications also after stomach cancer.
Yeah, I was mentioning we're getting ready to go to the Oncology Nursing Society meeting, and the whole issue with zolbetuximab is something we're definitely, because the nurses are going to be involved in terms of slowing the infusion, which is really interesting. I've heard that if the patient has a gastrectomy, they don't have as much problem because it's a direct effect in the stomach.
Yeah, correct. It's an on-target effect, and the tight junctions in the stomach, and if the stomach is taken away, patients will have that less.
So I'm going to get on to the last case, but just to point out, I thought one thing that was really interesting about these two studies is that they both showed a survival benefit at the first, I don't know why exactly. You kind of don't always see that, but there it is. The hazard rate's similar to PFS, and pretty cool that it's already there. And there's, the nausea and vomiting is going to have to deal with, and there's the timing that you were just talking about. We put a bunch of papers in here looking at these issues, but I want to get to this last case. This is a patient with metastatic GE junction adenocarcinoma, had a CPS of 20, and had a little bit different type of course than a typical patient with metastatic adenocarcinoma. Here's the case.
This is a patient with recurrent stage 4 PD-L1 positive GEJ adenocarcinoma, 66-year-old man who presented with dysphagia to solids. An endoscopy showed a mass in the GEJ extending into the cardia. On EUS, it was T3N0. PET at that time was negative for metastatic disease. He undergoes the standard treatment paradigm, chemoradiation followed by surgery. Unfortunately, a year and a half later, scan shows 2 new liver mets, and this was biopsy-confirmed disease recurrence. The PD-L1 score was high, CPS of 20, but this was before the Checkmate 649 data and the Keynote 590 data had really come out. So when he was first diagnosed with the recurrence, he started on FOLFOX, and then he had moved from California to Colorado. And once we were able to get our hands on nivolumab for first-line treatment, I added Nivo to 5FU. And then he had a series of very stable scans. And he was the one who first brought up, well, my disease has been quite stable now for several years. What's the next step? And so I brought it back to our multidisciplinary conference, and one of our surgeons decided to take him for robotic liver resection August 2021. And he remains disease-free until today.
And when they did the resection, they found that tumor?
Yes, they found tumor. And his CEA level had always been low level abnormal. And then after the surgery, it completely normalized. He's another patient where after the surgery, we were really hemming and hawing about what to give him after that. Should we continue on with some pseudo-adjuvant therapy or maintenance therapy? This is where we did do some serial ctDNA testing, and it was negative. And so we felt comfortable just stopping treatment altogether.
So any thoughts? It's kind of a strange thought to think that he had these liver mets sitting there for 2 years, and they took him out surgically, but I mean, there's still tumor there. I don't know. Any thoughts about this case?
Yeah. It's a special case. It's a nice case, but we see this type of patients a bit more today than we saw them 10 years ago. The concept of oligometastatic disease is also discussed at many meetings and on the strategy. If we detect oligometastatic disease being less than 3 or 4 metastases in these patients with gastric cancer, we would never go for immediate surgery. The better situation is also that it's not synchronous disease, but that the metastases do occur later on, because that's is a factor that determines the biology of the disease and the outcome. So if there is metachronous disease, like this patient here with the presentation sometime after the initial tumor, and then we start always with chemotherapy, then you can measure and have an idea on the biology of the disease. If you control the disease, if they are easily resectable, and if there are new metastases who do occur, then my strong advice would also be to take it out, to take them out in this situation. And yeah, we have regularly this type of patients, and what we do for these patients is a major impact on their outcome. Like the patient, like Dr. Kim said, for our patient, he remains free of disease after several years.
So a couple other things. You mentioned oligometastatic disease. I was hoping I would get a chance to ask you about this paper, definition, diagnosis, and treatment of oligometastatic esophageal gastric cancer, a Delphi Consensus Conference, European Journal of Cancer 2023. It's in the slide set somewhere, and you had some other presentations. A lot of stuff on oligometastatic disease and GE cancer. Want to bring us like a 1-minute summary?
Yeah, that's Delphi consensus meeting that we did to try to come up with a kind of a definition. That concept in GI cancer comes more initially from colorectal cancer. Now we are evolving that towards gastric cancer, esophageal cancer. The number of metastases plays an important role. The localization plays an important role. And it's to draw awareness that these patients do exist, and that the strategy may be different if we can control and understand the biology of these patients. As I said, as a comment on the case of Dr. Kim.
Can you think of an example where you've used local therapy recently on an oligometastatic situation?
Yeah, several times. Patients with I can think of a young man with initially very large metastasis, widely spread metastasis of a G-junction tumor. He was HER2 positive. We treated him. He was a very well-informed patient. We treated him with chemo plus trastuzumab plus pembrolizumab. He had a nice response. He had all liver metastases disappeared. The primary tumor disappeared. With endoscopy, with imaging, we didn't find, but there was one liver metastasis in the left lobe that stayed there several centimeters big, and we removed that. Then he stayed some time tumor-free, and then later on he developed a recurrence at the G-junction without metastasis, and then we took out the primary tumor, so in a second time. And now he's 1 or 2 years free of disease in this setting. So that's just an example and that patient would be interesting. He had initially very big metastasis in both lobes. This was initially not oligometastatic, but then he downsized and regressed to become oligometastatic. So that's a typical concept of what we see more often in colorectal cancer. It's not very frequent in stomach cancer, but these patients do exist.
So let's finish out by going from rare or unusual to extremely common. I saw this come into the chat room from Bertha earlier on. I'm like, yeah, we have to do this because everybody asks about this. So here's the question. You hear it probably every day. How do you approach a patient who has no response to neoadjuvant FLOT, high volume disease, but in this case, the PD-1 is 3%. And I'll also throw in, suppose it was 20%.
So the patient started with FLOT in a neoadjuvant setting. So that means he was supposed to have resectable disease.
Right. Went to surgery and had a lot of residual disease.
Went to surgery.
Had no benefit of chemo. Looked like the same. Didn't change.
Yeah, that's a difficult situation. If you had no benefit of chemo, well, the FLOT trials were there to show the benefit of pre and post-operative chemotherapy. If there was progression on FLOT, we will never give FLOT after the operation. If there was no progression and excellent tolerance, we may consider giving FLOT, although we feel not very easy because we say, does the patient really benefit in this setting? In the adjuvant setting, whether the PDL score is 3 or 20, today, we will not recommend a checkpoint inhibitor.
All right. Well, to be continued. So much out there. I'm really amazed at how far this field has come. And you've been such a huge part of it, Eric. It's great to work with you again. Audience, thank you for tuning in. Talking about things changing a lot. Coming back next week, we'll see what's going on with AML. We got menin inhibitors and a bunch of new therapies there as well. Be safe, stay well, and have a great night.
Thank you,
Thanks
Neil.
so much, Eric. Thanks. Great to see you.